This recording will go over cancer of the liver and liver transplantation. Cancers may be primary tumors starting in the liver, or they may be metastatic cancers that spread from another organ to the liver. Liver cancer is one of the most fatal types of cancer. Chronic infections with hepatitis B or C frequently lead to cirrhosis, which is a risk factor for developing liver cancer. It is important to remember that cirrhosis from any cause, including alcoholic liver disease, increases the risk for cancer. In the early stage of cancer, most patients are without symptoms. Later in the disease, they report weight loss, anorexia, and weakness. Ask the patient if he or she has or has had recent alterations in abdominal comfort, the most common concern. It is most often felt in the right upper quadrant before jaundice, bleeding, ascites, and edema develop. Palpation may reveal an enlarged nodular liver. Elevated serum alpha-fetoprotein, a tumor marker for cancers in the liver, testes, and ovary, and increased alkaline phosphatase are also common. Ultrasound and contrast-enhanced CT are both useful in detecting metastasis. If the primary tumor site is not known, a CT or ultrasound-guided liver biopsy can confirm the diagnosis, although this procedure is risky because of possible bleeding and spread of cancer cells. In regards to interventions, surgical resection and liver transplantation offer the only treatments for long-term survival from liver cancer. Unfortunately, most patients are not candidates for surgical removal because their tumors are unresectable. Tunneled abdominal drains, such as the Plerex drainage system, may be used at home by the patient and family to remove excess fluid, the acidic fluid that gathers in the abdomen and leads to ascites. Teach them how to empty the drain and maintain the system. Remind them not to remove more than 2,000 mL of fluid at one time to prevent hypovolemic shock. The primary treatment for non-resectable liver cancer is TACE, or transarterial chemoembolization. In this procedure, an interventional radiologist injects microscopic size embolic beads that have absorbed a chemotherapy drug directly. An angiographic catheter is advanced from the femoral artery and maneuvered into the liver and then directly into the blood vessel that is feeding the tumor. From there, the beads are injected. These beads clog up the tumor arteries, arresting blood flow as they release the chemotherapy. It is now becoming accepted practice to immediately follow the TACE with a microwave ablation of the same tumor. This burns or ablates the tumor to further slow any regrowth. Selective internal radiation therapy is reserved for patients with non-resectable liver cancer in an occluded portal vein. Other palliative approaches include hepatic artery embolization, ablation techniques, and drug therapy. Hepatic artery embolization causes cell death by blocking blood supply to the tumor in the liver. It is performed under moderate sedation by an interventional radiologist who threads a catheter through the femoral artery to inject small beads into the hepatic artery to block blood flow. Common ablation procedures include radiofrequency ablation, RFA, and cryotherapy. RFA uses energy waves to heat cancer cells and kill them. Cryotherapy uses liquid nitrogen to freeze and destroy the liver tumor. Chemotherapy may be used orally or IV. However, it is not effective in most cases. Another drug route is a catheter-directed method Another drug route is a catheter-directed method directly into the hepatic artery, a procedure called hepatic arterial infusion. The interventional radiologist places a catheter into the artery that supplies the tumor and injects a mixture of chemotherapy and contrast agent into the tumor. This procedure has the unique effect of depositing chemotherapeutic drugs directly into the tumor without causing major systemic effects. Patients with advanced liver cancer usually need end-of-life care and hospice services. Cirrhosis is the most common reason for liver transplants. Patients who are not considered candidates for transplantation are those with severe cardiovascular instability with advanced cardiac disease, severe respiratory disease, metastatic tumors, and the inability to follow instructions regarding drug therapy and self-management. Liver transplantation has become the most effective treatment for an increasing number of patients with acute and chronic liver disease. Donor livers are obtained primarily from trauma victims who have not had liver damage. Living donors have also been used and are usually close family members or spouse. The donor's liver is resected, usually removal of one lobe, and implanted into the recipient after removal of the diseased liver. In both the donor and the recipient, the liver regenerates and grows to a size to meet the demands of the body. Although liver transplantations are commonly performed, complications can occur. Some patients can be managed medically, whereas others require removal of the transplant. The most common complications are acute graft rejection, infection, and bleeding. The success rate for transplantations has greatly improved since the introduction many years ago of cyclosporine, an immunosuppressant drug. For patients who have undergone liver transplantation, monitor for clinical signs and symptoms of rejection, which may include tachycardia, fever, comfort alterations in the right upper quadrant or flank, decreased bile pigment and volume, and increasing jaundice. Lab findings include elevated serum bilirubin, rising ALT and AST, elevated alkaline phosphatase, and increased PT and INR. Transplant rejection is treated aggressively with immunosuppressive drugs. As with all rejection treatments, the patient is at greater risk for infection. Infection is another potential threat to the transplanted graft and the patient's survival. Vaccinations and prophylactic antibiotics are helpful in prevention. In the early post-transplantation period, common infections include pneumonia, wound infections, and urinary tract infections. Opportunistic infections usually develop after the first pre-op month. Latent infections such as TB and herpes simplex may be reactivated. The healthcare provider prescribes broad-spectrum antibiotics for prophylaxis during and after surgery. Obtain culture specimens from all lines and tubes and collect specimens for culture at predetermined time intervals as indicated by the agency's policy. If infection is detected, the healthcare provider prescribes organism-specific anti-infective agents. The patient should be taught to contact the healthcare provider at any time that signs of infection are present. The biliary anastomosis is susceptible to breakdown, obstruction, and infection. If leakage occurs or if the site becomes necrotic or obstructive, an abscess can form or peritonitis, bacteremia, and cirrhosis may develop. Please review the table in your textbook that lists assessment and prevention of common post-op complications associated with liver transplantation. For the patient who has had a liver transplantation, monitor the temperature frequently per hospital protocol and report elevations, increased abdominal pain, distension, and rigidity, which are indicators of peritonitis. Nursing assessment also includes monitoring for changes in neurologic status that could indicate encephalopathy from a non-functioning liver. Report signs of clotting problems, such as blood oozing from the catheter, petechia, or ecchymosis, to the surgeon immediately because they may indicate impaired function of the transplanted liver. Now we'll do some practice questions. Go ahead and pause the video to read the scenarios and pick out your answer, and then resume the video to hear if you're correct. For the first case study question, the correct answer is A. For the second case study question, the correct answer is B as in boy. For the third case study question, the correct answers are B, D, and E. For the final case study question, the correct answer is C. For question 1, the correct answer is D as in dog. For question 2, the correct answer is B as in boy. And for question 3, the correct answer is A.